Psych disorders. Basic questions we're going to be addressing in this lecture. What are the major classes of disorders, their subtypes, symptoms, and possible causes? And then we'll take a quick look at what life can be like for people with serious chronic psychiatric disabilities. All right, in the Discovering Psychology video that you watched, Philip Zimbardo talks about the major types of disorders. Can you remember the major types of disorders covered in the video? Well, here they are. Most common are anxiety disorders, mood disorders, or otherwise known as affective disorders, and then the schizophrenic or the psychotic disorders. So these are the three most common. These are the ones that we're going to be looking at in this lecture. There's a couple other types that are less common, but certainly are important and interesting. The somatoform and the dissociative disorders. The somatoform disorders aren't covered in your text. You're going to need to read the material I've provided links to in our web space. So certainly read about those. I'll just mention one or two of them. Hypochondriasis, for example, is a somatoform disorder. Somatoform disorders generally have to do with bodily complaints, physical complaints. So somebody who suffers from hypochondriasis shows excessive overconcern about their physical health. They're constantly worried and preoccupied with their physical health. They think they catastrophize any sort of symptom that they might manifest. They go to the worst possible case scenario. So excessive overconcern and anxiety about their physical health. Conversion disorders, another one of the somatoform disorders, and this is often something that involves for example, a paralysis of a limb, or real complaints about functioning of a particular bodily organ system or sensory apparatus. So somebody might go blind, and historically they called this hysteria. In Freud's time, they called it hysterical symptomology, that if somebody was hysterically blind when there was no organic or biological cause of their blindness or their paralysis. So this is conversion disorder. Falls within a class of disorders known as the somatoform disorders. So you'll read about those in the links that I've provided. And then the dissociative disorders, there's a couple to mention. One, probably the one probably most people are familiar with, is dissociative identity disorder. This is a multiple personality disorder. Certainly read about the dissociative disorders in your text. There's a couple other ones. Dissociative amnesia, that's where people become amnestic. They can't remember events, usually surrounding some trauma. Dissociative fugue, which involves a loss of personal identity. These are very interesting cases that have involved people sort of just wandering away and disappearing. And then when they're discovered, they've lost their memory of who they are. They don't know who they are. They're amnestic to the life they had in advance of the dissociative fugue manifesting itself. The difference between dissociative amnesia and dissociative fugue is in the fugue state, there's the loss of personal identity. This is the big difference between simply losing your memory around a trauma, which is dissociative amnesia, and dissociative fugue, where there's this loss of personal identity. And in almost all these cases, there's usually some precipitating trauma. In cases of dissociative identity disorder or multiple personality, in almost all the cases for which there's been case studies, there was some evidence of abuse as children, and this is just ritualistic, sadistic, physical and sexual abuse that went on and on. And if you recall, when we talked about the section on consciousness, I told you a story about my sophomore year in high school creative writing teacher, John Fogus, who had the experience of floating above of his body when he was on patrol in Vietnam as a soldier, and we called it dissociation back then. That's how we explained that, that his consciousness split into two different streams, such that his body could carry on in a sort of automatic way while his consciousness sort of split off. His sense of self and so forth was kind of split off, separate and apart from his body, or at least that's what his perception was. So dissociation is a psychic defense. That is, if you're a child and you're being abused, what else can you do really but disengage psychically from what's happening? Because certainly you can't just walk away. I mean, some kids do, but for most kids, it's, you're powerless. You can't really leave because where are you going to go? Some kids have the wherewithal to do that, but many don't because they trust, they love, and they're afraid. And so dissociation is a form of psychic defense where you sort of split off. You leave psychically where you cannot leave otherwise. An awful situation. So read about those dissociative disorders. We're going to be looking at anxiety, affective, and schizophrenic disorders in this lecture. All right, so here's case study number one. We're going to explore these by way of case studies, and we're going to kind of check in with your knowledge a little bit. Certainly, you have some background in this already because you've done some reading. Hopefully, you've seen the lecture that preceded this, and then maybe you've come to this class with some pre-existing knowledge about psych disorders. So here's case study number one. Terry complains that he's experiencing sudden episodes of overwhelming fear each time he crosses the bridge. His symptoms include dizziness, rapid heart rate, shaking, and intense feelings that something bad is going to happen. So what among those general disorder types do you suppose Terry is suffering from? Is it an affective schizophrenic or an anxiety disorder? If you guessed anxiety, you're probably right. Somewhere between 19 and 30% of adults will be diagnosed with an anxiety disorder, of which there are a few. We'll look at those briefly in a minute. So the general symptoms of anxiety disorders, you have the physical symptoms of increased heart rate, respiration, and so forth. So your body is preparing to deal with a stressor, fight or flight. Acute sympathetic activation, feelings of dizziness. So there's more somatic symptoms, muscle tightness, tension, tremors, shaking. Psychologically, there's this intense apprehension or this feeling that something bad is going to happen, feelings of dread. Different subtypes of anxiety disorders, phobias, generalized anxiety disorder, panic disorder, often co-diagnosed with agoraphobia, PTSD, and OCD. So we'll just go through these really pretty quickly. So the phobias you can think of as being an intense fear reaction or anxiety response to a situation or a thing that goes well beyond what we would consider to be normal or adaptive. So people can have intense fears of crossing bridges, for example. So much so that they have to reorganize their life around this fear, which makes it maladaptive. And certainly the person is in distress. Generalized anxiety disorder is kind of the opposite of a phobia in that the object or the situation is really not clear, but rather the anxiety is all pervasive. It's free floating, as they say. That is, you can't quite nail down what exactly it is that's causing you the anxiety, but rather you just feel anxious all the time. Panic disorder is something that involves having these intense panic attacks, so intense anxiety attacks, and they can come on pretty much anytime, anywhere. Often co-diagnosed with a disorder known as agoraphobia, which is essentially the fear of the marketplace, fear of going into open places. Often people with panic disorder become shut-ins because they are concerned that if they go to the mall or they go out or for a walk or something like that, they'll have a panic attack, and then somebody will call 911, and then they're going to be embarrassed and so forth. So they just stay home. Post-traumatic stress disorder is a disorder that showed up. I probably should have this date, but it wasn't in existence as a clinical diagnosis in advance of, I think, the early 70s, and then it was began to be included in the DSM after that. And what really kind of precipitated this was as people like my sophomore high school teacher returned to the United States from combat situations in Vietnam, they had a really hard time. And this is not something that was new. That is, soldiers who had been in war had come back and had a really tough time readjusting to civilian life. They had all kinds of psychological problems, um, flashbacks, and suffering from severe anxiety and anger problem, drug and substance abuse, inability to really kind of adjust, and impacts their work life, their social life, relationships, and so forth. And so historically, it was referred to as shell shock or battle fatigue, um, but but now we know it to be post-traumatic stress disorder. And you don't have to go to war and experience combat to be diagnosed with PTSD, but rather, in some cases, a single event, a single traumatic event can be enough to warrant the diagnosis of post-traumatic stress disorder, particularly when the person thereafter is struggling with the emotional memory surrounding their traumatic event. So you see this in cases of rape, and other cases where people have been traumatized. Some individuals will suffer continually from an anxiety disorder known as PTSD surrounding this. OCD, or obsessive compulsive disorder, um, it's a disorder that I think probably a lot of people have heard of or know something about. Um, it involves obsessions and compulsions. So the obsessions are the thoughts that you can't stop. So some people with OCD are counters. They count everything, or they can't leave the house because they're obsessed with the idea that they've left their oven on or something like that. And then the compulsive part of this is the behaviors that are associated with the obsessions. So if I'm pestered with the obsessive thought that um, um, I've left the oven on, then the behavior is this constant checking behavior. I keep, checking and checking and checking. Some people are obsessed with dirt and germs, so they are compulsively washing their hands to the point where their hands are bleeding in some cases. So these are some of the subtypes of anxiety disorders that an individual can be diagnosed with. The cause or the etiology, so we'll just go through these pretty quickly. And this is again the biopsychosocial model that we look at: biological factors, psychological, and social factors. So organic or possibly biological bases include action at glutamate and GABA receptors. So these are the primary excitatory and inhibitory neurotransmitters in the brain. If there's overactivity at the glutamate receptor sites, or at the GABA sites, basically glutamate turns us on, GABA turns us down. People who take anti-anxiety drugs, it tends to affect the activity at these um, neurotransmitter receptor sites to help alleviate the symptomology. Serotonin is also implicated in anxiety disorders. That's why, at least in part, some people are being described a class of antidepressants known as the SSRI class of drugs to treat anxiety. So there's something going on at at the level of the neurotransmitter, level of the synapse, that that contributes to symptoms of anxiety. Psychodynamic, or so from the Freudian perspective, maybe there's some repressed infantile conflicts. So maybe somebody's struggling with desires to aggress or sexual motivations and so forth, and they have to repress these basic motivations. And so certainly there's this conflict going on, often at the unconscious level, but it bubbles up and affects somebody's conscious life, in that they experience this conflict going on unconsciously as anxiety. The learning theorists have something to say about anxiety disorders, the etiology. So we saw in the section of learning Watson's classic and infamous study with little Albert, where he classically conditioned little Albert to fear white rats by pairing a loud sound with a white rat. So in some cases, anxiety are the things that we're afraid of. In cases of phobia, we've learned this fear modeling. For example, if we see other people react with extreme fear or anxiety when in the presence of a snake or something like that, we can acquire that fear ourselves just by watching somebody else be afraid of something. We can become very afraid of that thing too. Verbally, right? So we can experience others talking about responding to particular things, and therefore we can kind of learn, acquire their fear simply by listening to people talk about things that they're afraid of or things that we should be afraid of. Cognitive folks, people with anxiety disorders seem to be very, very excessively, scanning their environment for threats, excessive attention to perceived threats. Where one person wouldn't perceive some event or some situation as being threatening, somebody with an anxiety disorder might pick up on that. And then stress, and there's all kinds of types of stress, conflict that is being torn between doing something and not doing something. There's pressure, work responsibilities and relational responsibilities and that sort of thing. So stress is one of these factors that can precipitate an anxiety disorder, and it's also common to all the disorders that we're going to be looking at, as you will see. All right, so case study number 2. Bruce complains that he no longer enjoys doing the things he used to do and that he has felt hopeless and sad most of the time for the past 3 months. He sleeps pretty much all day, every day, which causes him to miss work, and he has no appetite. So which among the general disorder types do you suppose Bruce is suffering from? Anxiety, affective, or schizophrenic? If you guess affective or mood disorders, you are correct. Probably major depression. So we're going to look at these general symptoms. So this first one, you'll see in the DSM-Access one, a list of symptoms that accompany major depression. So you'll see at least 2 weeks of depressed mood, loss of interest in the things that you typically enjoy doing, significant weight loss, sleep problems, insomnia, or maybe sleeping all day, every day, motor issues, so either restlessness or sluggishness, cognitive issues, inability to make decisions, can't concentrate, can't pay attention. Some people experience suicidal thoughts, suicidal ideation. And in the case of bipolar disorder, which is a type of mood disorder where one swings from being majorly depressed to a state that involves excessive elation, euphoria, optimism, grandiose ideas, impulsivity, psychosis. They're on top of the world in a manic phase. So if somebody is showing signs of depression and mania, they're probably suffering from bipolar disorder. All right, so 2 subtypes. There's more than this, but we're going to look at these 2 major subtypes of depression. So major depression and bipolar disorder. Major depression, more common than bipolar. Somewhere around 13 to 70% of adults will be diagnosed with major depression. Somewhere between 1 and 2.5% will be diagnosed with bipolar disorder. And again, bipolar disorder involves this cycling back and forth between periods of depression to mania. And there's different types of bipolar disorder. Well, subtypes, like there's rapid cycling, where somebody's sort of rapidly cycling through these phases of depression and mania, whereas some people cycle through them rather slowly. Etiology, so again, the biopsychosocial, so organic or the biological basis, again, at the level of the synapse or the level of the neurotransmitter. So both the neurotransmitters norepinephrine and serotonin have been implicated in depression. And again, antidepressants work at the level of the neurotransmitter by making more of these neurotransmitters available at the level of the synapse. That seems to reduce symptoms. Learning, one of the models of depression that comes from the learning folks is learned helplessness, and the researcher that is primarily responsible for this model is Martin Seligman. And what Seligman did was look at animals who he exposed to inescapable electrical shock, and the animals they used were dogs. So what you do is you train an animal to escape painful electrical shock, and then you make it impossible for that animal to escape. And then what happens over time is the animal, when given the opportunity to escape, will simply not take that opportunity, and they actually have to go in and pick the animal up and basically demonstrate, model how to escape that inescapable shock. So this is learned helplessness. That is, you'll learn to not try to do anything to try to pull yourself out of the state that you're in. And you see this in major depression, that people will submit to the disease, and it's not something that's willful, but rather depression just is all-consuming, and people become hopeless and helpless, and in such cases they actually would benefit from somebody coming in and really intervening and helping them sort out their issue. So the cognitive folks look at sort of thought and as a precursor to depression. So people who are depressed are typically more pessimistic. They think negatively about themselves and about the future. And then the cognitive model supposes that that is at least in part, the cause of the depression. It's difficult to sort out the causal path, though, because it could be that the depression causes the negative thinking. But there's been a lot of research on this, and there is some evidence to support that it's the negative thinking that causes, at least in part, the onset of the depression and the maintenance of the depression. And then stress, there's certain factors like losing a loved one that can certainly precipitate depression or factor in the onset of depression, divorce, which is like a death in many cases. So there's certain psychosocial factors, environmental factors that can precipitate the onset of depression. All right, case study number 3. Robert has become socially withdrawn and his behavior is bizarre. He claims to see things and to hear voices telling him to do things. Believes the FBI has planted a bug in his brain that is monitoring his thoughts. His attention to personal hygiene has fallen off precipitously. He recently was let go from his work because of his inability to interact effectively with co-workers. General disorder type, well, there's only one more. The schizophrenic disorders. About 1% of the adult population will be diagnosed with schizophrenia. General symptoms of schizophrenia, we can parse the general symptoms into positive and negative. So you can think of positive symptoms, not in the ordinary sense of positive meaning good. It doesn't have to do with that at all. But you can think of them as sort of excesses, additions to our ordinary thoughts and behaviors and so forth. So, for example, irrational thought or delusions often are present in cases of schizophrenia. Delusions, somebody might believe that they're the second coming of Christ, or They might have delusions of paranoia that somebody's out to get them and they're being monitored and so forth. And that seems to be the case in Robert's situation. Um, Disorganized thinking, so much so that when you try to articulate something, or you hear somebody with schizophrenia trying to describe some event or something like that, it doesn't really make sense. Distorted perceptions, hallucinations, for example. People can experience visual hallucinations. They can see things that aren't there. They can hear things that aren't there. They can feel things crawling on their skin that aren't there. So hallucinations can run the full spectrum of our sensory apparatus. Disorganized or abnormal behavior, that is purposeless movement. Some people walk back and forth. They have aimless behaviors that are repetitive, and they don't really seem to be being done to accomplish anything. And then the negative symptoms are decreases or absences. So one of the first things you see happen is deterioration of adaptive behavior. So hygiene, people stop taking care of themselves. Their social relationships deteriorate, begin to fall apart at work. Other sorts of, maybe intimate relationships begin to suffer, family relationships, because of the person's bizarre behavior. And then schizophrenia is often thought of as a thought disorder, but there's also an affective component, certainly. So in some cases, you see disturbed emotions. That is, their emotional responsivity kind of goes away in flat affect. They don't seem to respond emotionally to anything. And then there's some cases where people will respond in sort of bizarre ways emotionally. So somebody might be laughing hysterically at a funeral or something like that. So there's a disconnect between the emotional expression and the situation, such that it's inappropriate. Different subtypes. So that positive and negative view of symptomology is one way to look at symptoms. In the DSM, you'll find that that schizophrenia disorders come in different types. So we can look at the symptomology as being certainly generally either positive or negative, or some combination of the two, and then we can also further qualify somebody as being one or the other of these types, or suffering from one of the or the other of these types of schizophrenic disorder. Sometimes it's easier to think of in terms of positive and negative symptomologies rather than to try to locate somebody in one of the other of these subtypes. Sometimes it's hard to do, but certainly these subtypes exist. So we'll talk about them a little bit. So the paranoid type is characterized often by delusions of persecution. That is, you think somebody's out to get you. Delusions of grandeur. That is, you think you're much more important than you actually are. Auditory hallucinations. These are voices telling you that somebody's out to get you, and that, or maybe in some cases you need to defend yourself by harming somebody else, or yourself possibly. The catatonic is characterized primarily by motor disturbances. So sometimes people will freeze into positions, or they'll be hypermotile. They won't be able to stop moving. The disorganized type collection of symptoms include flat affect or emotional indifference, social withdrawal, which is in some cases common to the other subtypes, but people become very withdrawn. They become shut in. They don't interact with anybody. Disorganized speech or word salad. That is, you might hear the person talking, but what's coming out of their mouth doesn't make any sense. Disorganized behavior. This is sort of this repetitive, purposeless behavior. Somebody might pace back and forth or whatever. Their behavior lacks any sort of goal orientation. And then the undifferentiated type is reserved for people with symptoms that don't fit neatly into one or the other of these categories, and then you would qualify them as undifferentiated type. So it could be a collection of these different kinds of symptoms, so much so that you can't categorize them as being paranoid, catatonic, or disorganized, but so they fall into undifferentiated type. So let's talk about etiology a little bit. So let's look at the biological basis. So what you're looking at here is a chart that describes concordance rate as a function of genetic relatedness. So let's look at identical twins who share 100% of their genes. When one twin has it, what's the likelihood of some other of their identical having it? So approaching 50% of the time. That's what concordance is. That is the extent to which when one person has it, what fraction of the time does the other one have it? So with identical twins, you have 100% genetic overlap. So about half the time when one twin has it, the other twin has it as well. And then you can see as we decrease the percentage of genetic relationship, what happens to the concordance rate, it goes down too, so that you can see that when we are looking at unrelated person in the general population, that is, you pass a stranger in the street, what's the likelihood if one person having it, the other stranger in the street has it? So roughly 0%. So what this suggests is a couple things. It suggests that schizophrenia is at least in part genetic in origin. Otherwise, you wouldn't see such high degrees of concordance in identical twins and such low degrees of concordance in strangers. But it's also suggesting that there's an environmental component as well, because if there was an environmental component, you would expect, and it was 100% genetic, then you would expect to see, perfect concordance among identicals, but you don't. It's about half the time. So what this suggests is that there's something going on in the person's environment. Certainly, the person is predisposed to schizophrenia if genetically predisposed, but if they land in a particular environment where something happens environmentally that that supports the genotype becoming phenotype, manifesting itself, then certainly there's an environmental component that needs to be looked at as well. So structural abnormalities, this is something that has been observed in people with schizophrenia for quite a while. That is, the ventricles in the brain, these are those spaces that are filled with cerebrospinal fluid, are much larger in people with schizophrenia than normal. So the question is this a cause or a consequence of schizophrenia? And that hasn't been sorted out. But what's clear is that there's tissue loss in around these ventricles in people with schizophrenia as compared to normals. And that's a pretty reliable observation. Precipitating stress, again, there's all kinds of different kinds of stressors. So you can have major life events, cataclysmic events, your house burns down, or there's an earthquake or something like that. There's the demands of daily life, all that it requires of us, going to school and work and relationships. And then there's hassles like dealing with traffic and all those other little things that we experience that causes stress during the day. Certainly we don't have to have a major stress or life event occur to suffer from stress. Rather, the demands and hassles and so forth can accrue such that we're in a constant state of stress, psychological stress, and this is a major precipitating factor and can support the onset of schizophrenia. So it's an environmental factor that needs to be considered. And then there's a lot of work being done in this area, the neurodevelopmental hypothesis. And what this really has to do with is that maybe there's something happening either prenatally or neonatally, such as virus, maybe nutrition issues, obstetrical complications. Maybe there's some anoxia, there was some lack of oxygen during birth, other brain insults that create subtle neurological damages that can set the stage for the later onset of schizophrenia. All right, so let's look at prognosis. So 10 years out after being diagnosed with schizophrenia. And by the way, schizophrenia has the poorest diagnosis, or the least positive diagnosis. So about half of people will get better. And certainly their condition has to be monitored and managed with medication usually. But about half the time people will recover well enough or become well enough to function independently, work and have relationships and that sort of thing. 25% are improved but require a strong social support network. So hopefully family members will be able to step in and support. I worked in mental health for quite a few years as a case manager with people suffering from severe chronic psychiatric disabilities. A good portion of them were people with schizophrenia. And I was that strong social support network. I helped them. I took them shopping, helped them connect socially, helped them stay compliant with their medication, and so forth. About 15% remain unimproved, typically hospitalized. So some people will be institutionalized nearly their entire adult lives once diagnosed. They won't improve to the point where they're able to function independently or even semi-independently. About 10% will end up committing suicide. So you can compare this against the 0.1%, 0.01% in the normal population. So fractionally, it's much higher in people with schizophrenia, which is pretty sad. So something to consider, and I have this as a sort of something to consider at this point because a lot of students will confuse positive and negative symptoms. So I want you to consider or think about what we talked about as being positive and negative symptoms of schizophrenia. And then what I'd like you to do is just to come up with an example of each of these types of symptoms and how it affect a person's functioning in their workplace. So what I'm doing is trying to help you to develop a memory code for positive and negative symptoms. So if you pause this and do that now, that would be great. All right, so think about positive and negative symptoms. So you think about positive as being additions or excesses, and negative being subtractions or decrements or deficits. So an example of a positive symptom affecting somebody's functioning in the workplace. So if somebody's having bizarre thoughts or delusions, and they're communicating that to individuals in the workplace, probably that's going to affect their ability to get along socially, quite possibly to do their work. If they're experiencing negative symptoms, if they're not taking care of their personal hygiene, then quite probably that'll affect their ability to get along in the workplace as well. All right, so just to finish up here, I'm going to just talk a little bit about what life is like or what it could be like based on my experience in mental health and other things I've done with respect to learning about this stuff. So often it can begin with a hospitalization. And this can be either voluntary or an involuntary commitment to a psych unit. And often this can be a relief to the individual who may be struggling with symptoms, and their family members are perplexed as to why they're having such trouble. So sometimes this can be a good thing. Often it can be a good thing because somebody will emerge with a diagnosis. They could be involuntarily committed if they're determined to be a danger to themselves or others, or they're unable to provide for themselves. So people can have themselves admitted or go voluntarily, or it can be involuntary. And then after spending some time in the unit and ideally emerging with a diagnosis and a treatment plan, Um, there's a discharge process, and this is a carefully thought out process, because when somebody's on a hospital unit, um, you know, where are you going to release this person? So usually there's a social worker, a clinical social worker, um, who manages that discharge. Often it's back to the family. Um, so this can be a good thing, or it can be a not so good thing. It can be difficult readjusting to family life if you've been on your own for a while. Certainly it creates stress in the family system. It's particularly problematic for the patient in families with a so-called high expressed emotion communication patterns. And what this is, and there's plenty of research that's been done on this, is that some families have what are called high EE patterns, communication patterns. And what these patterns are characterized by is high degrees of hostility in communication. So highly critical. You might have a mom or a dad that's highly critical of the person. Why can't you get your act together? Look at your brother. He's very accomplished and achieving great things. And look at you. You can't even keep a job. To emotional over-involvement, that is enmeshment, that is the parent or the caregiver can't separate out themselves from the person, that is they start attributing the cause of the person's disorder to themselves and become very sort of emotionally distraught and over-involved with the person. Excessive over-concern to the point where it's counterproductive. It's creating more stress. This emotional over-concern and enmeshment and over-involvement is creating more stress for the patient uh, than um, than doing good, than being helpful. So, what this pattern does in some family systems is send the person right back to the hospital because it's so stressful to be in that family system. And again, stress is one of those factors that can support the onset of schizophrenia, but also can increase recidivism. It creates a situation where the person is uh, so stressed out after being discharged that they go right back into the hospital. Um, Discharge can often involve being placed in a transitional residential home, or a halfway house as they're referred to. So I worked in transitional residential homes as a case worker. So the place that I worked had different tiers of residences. So there were residences that accepted people right out of the hospital, and often these people needed help sort of relearning how to take care of themselves, take their medicine, cook themselves a meal, and so forth. And then there were different higher level functioning people went on to live either semi-independently um, in what we called satellite houses. So these folks had quite a bit more freedom than those living in the facilities that were set up to receive them right out of the hospital. So their residence sort of mapped onto their level of functioning. Many people with chronic psychiatric disabilities live semi-independently, and these high functioning folks live in these satellite houses, or they're parts of organizations that are that have support systems available to them, or they might even live independently. I saw a few people sort of transition out of the company that I worked for to get their own apartments, and really some of them had jobs and that sort of thing. Worst cases are these sort of revolving door cases. That is, they're in and out of the hospital. Many end up living in the street. So about a third of the homeless that we see are suffering from some sort of psychiatric disability, often schizophrenia or bipolar disorder or major depression. And it's often comorbid with substance abuse problems. All right, so learning objectives to focus on. Here they are. Notice that there's a red font objective. So read about somatoform disorders, and I provided web links to information on the somatoform disorders, and then reading your text about the dissociative disorders. Know something about the symptoms, causes, and the subtypes.